Hi friends, good evening. I'm Dr. Ashutosh Gupta, and today we're going to talk about pregnancy in bicornuate uterus. Right, so anatomical abnormalities into the uterus, they can be in the range of 5 to 7%. Right, but we are specifically talking about the bicornuate uterus. So we are not going to we are not getting into the classifications, and then but exclusively the bicornuate uterus can happen in something around 0.5 to 1% of the general population. Right, now we talk about the pregnancy. If the pregnancy is there in the uterus, then what can go wrong and what we can expect, right? Since it is the fusion defect, right? So instead of having a whole cavity which expands during the pregnancy, so we are having only one of the horn in which the pregnancy would be there, right? And which is going to grow. So meaning thereby that with this incomplete fusion of those Mullerian ducts, what we can have is this, that we can have some short or abnormal cervical fibers leading to cervical incompetence. So this is the first and the foremost thing that probably we would be looking around for during the pregnancy. Secondly, since the pregnancy is in this one horn, and then that horn would go to its own capacity to really support the pregnancy. So probably what we can think of getting up to is something around 32, 34 weeks, and 1.6, 1.7, 1.8 kgs weight would be our target. That probably this could be the weight of the baby, and this is the and therefore we would have the delivery by the time. So we can have a prom, we can have a premature observed membranes. Usually it is the that horn in which the pregnancy is there, and therefore we can have malpresentations. So meaning thereby that instead of cephalic, instead of the head down, we can have a head up, which has become a breech pregnancy. Right. The first and the foremost thing is this, that probably the side on which the horn would get gravid and would expand, probably we expect कि वहीं की that side or that side ipsilateral side would have a good uterine artery flows. So contralateral meaning thereby that if the gravid horn is to the right hand side, so the left uterine artery is going to misbehave. So meaning thereby that no matter these Klexanes of the world and then the LMWH of the world or the equation of the world is going to help that flow that is from the left uterine artery. Pehla. Second, since there is some mere amount of a flow and therefore we are having the baby adjusted into a single horn, this is a classical case of it to be an SGA. So labeling it to be an IUJR becomes a misnomer, right? And the third thing that probably we need to identify is the umbilical artery flows. And umbilical artery flows and the amniotic fluid, if it is normal, then probably we can really take the pregnancy up something around 30 to 34 weeks and so on and so forth, right? So let us first see these slides and then we'll talk about all this. So this is a good case. This is a primary gravida with a bicornuate uterus. What we are identifying, we are seeing her for the second time, and then the lag of the baby is almost the same. So it is at -5 SD, and this is a small for gestational age. This is not an IUGR baby. So all the biometry that you talk about, the fetal weight, the BPD, HC, AC, FL, they are at -2 SD, and then the interval growth of the baby is absolutely great, right? And then this fetal medicine is all about mathematics, right? So we expect that the uterine artery on on the side of the gravid uterus would be normal, and then the contralateral side would be abnormal, right? So you can see that the one of the uterine arteries is normal, and then the other uterine arteries is really abnormal. So we are not worried about that uterine artery, or we are not worried about that flow. The rate limiting would be the umbilical artery flow. So that would be in high normal stages, right? Okay, so the RI, PI for the umbilical arteries is well within the normal range. Secondly, I would wish to see the amniotic fluid, which is normal in our case, right? So few things that probably we would know beforehand doing all this assessment to the baby is this, that probably we would deal with a small for gestational age baby. The side on which the gravid uterus is there, that side the uterine arteries would be normal, contralateral uterine artery would be abnormal. I would be looking around for the umbilical artery flows and then the amniotic fluid index. Then third part is the if both of them are normal, what I feel is this, what I believe is this, that the interval growth of the baby would be absolutely great. And this bicornuate uterus with pregnancy falls into the criteria of being in a small for gestational age. Like I have shown you that all the parameters in two successive sort of an ultrasounds that we have looked around for, it was falling at the -2 SD. But I'm not worried about those -2 SDs and all those stuff. The interval growth is absolutely great, and this is not an IUGR baby. This is in small for gestational age because the uterus is big, because the house in which the baby is being housed, it is small, or we are having only one rudimentary horn, and therefore this SG is expected, right? Okay. So I had been telling all these things. Fetal medicine is all about mathematics. So what we are getting, what we expect, if it matches, then we are happy about it, right? Okay. Thank you very much for your patience.